Welcome to Variations 4, the musculoskeletal unit. Today we'll be covering questions 12 to 16. The overall theme of these questions is fracture management. So question 12, first review the basic physiology of fracture healing in map 8. So what is the main point of this little map here that is taken basically out of your Lewis textbook? If you're going to get something out of this diagram here, or this map, I would say the main point is the importance of the stabilization of the limb during healing. For example, up until the first 2 weeks after the fracture, all you've got there is some hematoma, some blood, and some early granulation tissue between the 2 points of fracture. Not going to give you a lot of strength. Therefore, the limb is going to need help with immobilization, whether it's a cast or traction or an internal fixation. So when we talked about the total hip replacement, we're putting hardware inside the joint and we're leaving it there. That's called an ORIF, open reduction. So they've had to open up the patient, go in there, reduce the fracture, and they've put things in to hold the new joint in place. Internal fixation. Everything we talked about basically with the knees and the hips up to now has been open reduction, so surgical incision, internal fixation, hardware put in, left in there. Sometimes you'll see open reduction, external fixation, and that's where you might see pins coming out of the body to the exterior. We'll talk a little bit more about that stuff in INP. Nonetheless, we need some kind of stabilization here. As was said, by day 14, you've got this bone beginning to form, but it takes from 3 weeks to 6 months, depending on the injury, before you can actually start putting weight on that, before it's strong enough to put weight on, before it's strong enough to start removing the cast and then mobilize, before it's strong enough to remove the patient off of traction and start mobilizing. And it can take up to a year or more before it really gets to its full strength. Again, the importance of exercise, because exercise helps calcium stay on the bones and strengthen them. Number 13, the overall collaborative goals in fracture management. What are they? What are the 3 overall goals in fracture management? They're listed right here. Reduce, number 1, reduce the fracture. Number 2, immobilize it. Number 3, restore function. So reducing the fracture, again, could be opening up and putting the internal fixation in, such as what we talked about yesterday with the various hip surgeries. External fixation, which I talked about briefly above, and we'll go into more of that in INP. A closed reduction is when you've seen or heard of this, that the emergency physician is able to manipulate the patient's limb without any surgery to put the bone back into place. And traction is a system that holds things in place too. We don't see a lot of that these days. How do we stop the fracture How do we keep the fracture in its proper alignment during healing? Well, again, you can have this internal, external fixation, casts, etc., etc. And then pretty early on, we're starting with physio. Even if the patient's non-weight bearing, there's physio exercises that can be done without putting full weight or partial weight on the limb. 14, what are some additional points for casts, external fixation, etc.? Looking at map 9 for that. You want to keep the cast above the heart to avoid blood flow being kind of trapped in that lower extremity and causing unnecessary swelling. If you have external fixation, let's just find you an example of external fixation here. Here's an example of someone with an external fixation device on their leg. Your main responsibilities, as you know, your usual assessments, of course, assessing for infection, assessing neurovascular status. Yeah, for sure. And in addition, really, these are called the pin sites, and that's where the pin enters the skin. As well as assessing it, you're going to be responsible for cleansing those sites, multiple sites, with sterile saline. There's some additional points here on drug therapy. I mean, we're talking about avoiding infection. We're talking about, you know, vitamins. We're talking about pain meds. It's kind of, there'll be all kinds of meds, anticoagulant meds, nausea meds. I guess we'll get more into that when we go to clinical. Next question, number 15, discuss aspects of a neurovascular assessment. As I said, we're going to get into this in a little more hands-on detail in INP, but I mean, to summarize, how would you summarize a neurovascular assessment? What are we trying to assess for in a neurovascular assessment? In your own words, what would you say? So while we will get into it in a little more hands-on later on in a different course, the essence of it, of course, is neurological and vascular assessment. So that's assessing nerves and assessing blood flow. After surgery, you could have bleeding, you could have swelling, or you could have direct injury from the surgery itself. You want to assess for these things. So obviously, you've got elements here that have to do with your usual CWMS stuff, your cap refill stuff. That's all your circulatory stuff. You've got movement sensation, which is neurological. And you've got the assessment of specific nerves in the extremity, which we will look a little more at in INP4. So the final question of this section asks us to re-examine, look at what does a hip dislocation or re-dislocation look like. So what I'm getting from what I'm looking at is that certainly pain, spasms, certainly your patient may have heard a pop when they have a dislocation or re-dislocation. They're probably going to complain of pain and spasms. In terms of your examination, it really depends on what kind of hip dislocation it is. If it's posterior, in terms of where it's being dislocated, near the posterior of the hip joint, then you get this internal rotation. If it's anterior, so more of the front portion of the joint has been the place where it's popped to, depends on which area the femur head is going. If it's going towards the anterior, then apparently it's going to twist the foot in an outward direction. I'm quite happy if we just sum it up though, because when we think of hip replacements now, we don't typically worry too much about posterior anterior. What we'd be assessing for in anyone who fell or in a patient who's complaining of that hip pain is we'd be assessing for that pain and spasms, And then certainly on examination, we'd be assessing for a shortening of the leg. You can see the affected leg is somewhat shortened in these examples, and an abnormal or unnatural kind of facing foot, either it's rotated inwards or rotated outwards. Those three things would be enough to say, and plus their history, to say, I think we've got a read dislocation here. Let's call the surgeon.